think we might make a start. It's gone 4 o'clock, and I'd like to welcome you all to the event for this afternoon, the final perspectives of the year. My name's Jenny Phillip, and I'm the Professor of Palliative Medicine at University of Melbourne St Vincent's Hospital, and in collaboration with the VCCC. And I'm very proud to be hosting this on behalf of the Palliative Nexus Research Group. If I could begin by acknowledging the traditional custodians of the land. I'm on the land of the Wurundjeri people of the Kulin Nations. I pay my respects to elders past and present. And I also wish to acknowledge any Aboriginal and Torres Strait Islander people who might be in the audience today. This is our final perspectives of the year, and I'm hopeful that the computer software holds out. I'm not sure if it's the rain or just what's going on, but there's a few gremlins in the system this afternoon, so hopefully all will be well. But it's my pleasure to introduce you to this event, which is the Changing Nature of Oncology. What does this mean for palliative care? Today we're having a panel discussion, which has been our established tradition over the last 4 years since we began doing these perspective sessions during the COVID lockdown. And it's a great way for us all to come together as a group throughout the year, but also I think at the end of the year to have some thoughtful discussion and some terrific leaders and thoughtful people come and help us explore interesting and different topics as they relate to palliative care. And today is certainly no exception. We have a terrific panel, and I'm very much looking forward to what they have to say. So I'd like to introduce them. So first is Professor Sue-Ann McLaughlin. Sue-Ann is the Director of Oncology and Cancer Services at St Vincent's Hospital, Melbourne. She's a medical oncologist who specialises in the treatment of gastrointestinal cancer. And she's an active clinical researcher and supervises a number of higher degree research students. And her particular research interest is in patient-reported outcomes, where she uses mixed methods to progress these research questions and important concepts. So welcome, Sue-Ann. Next is Brian Lee. Professor Brian Lee is a palliative medicine physician and medical oncologist. He's a full-time clinician who, as he says, dabbles in research and a reluctant service administrator. He's the Director of Palliative Care at Peter Mac and Royal Melbourne Hospital. And he's also a current co-chair of PACS, which is the National Cooperative Trials Group in Palliative Care, which conducts clinical, pharmacological and pharmacovigilance trials, as well as consumer-directed research across Australia and internationally. He's published extensively in the areas of clinical trials, early palliative care, health services, and palliative care for vulnerable communities. Welcome, Brian. And thirdly, Mary Duffy is an advanced practice clinical nurse consultant in the lung cancer multidisciplinary team at Peter Mac. Mary works primarily with people who have been diagnosed with lung cancer or mesothelioma and their families. And she's worked in this space for over 25 years in a variety of roles, but she is renowned and deeply valued for her wisdom, her commitment to care and her compassion. So welcome, Mary, and welcome all three of you to this I think hopefully interesting and slightly, perhaps challenging topic of what does the changing nature of oncology mean for palliative care? And just to set the scene, I think it's true almost that every week there's a new announcement in the news about another cancer breakthrough. And I just did a quick Google about, new cancer treatments, and there was a breakthrough that may overcome cancer treatment resistance from Peter Mac, and a news article from WeHi around a 2-in-1 breakthrough cutting-edge immunotherapy for brain cancer. The World Economic Forum has talked about 12 new breakthroughs in the fight against cancer, and Science Daily, a new cancer agent, works without oxygen. So there's lots of excitement in the media, and the landscape is changing, dramatically different from 20 years ago when chemotherapy was really the mainstay of systemic treatment for people with cancer. And really at that time, much of the trials, at least from my observation, were around testing incremental benefits rather than necessarily a sort of a whole different way. But with the new agents, it's now very different. It's very fast, it's moving, and it seems actually almost a bit dizzying to try to keep up. And there's a lot of optimism around this, with all the opportunities of new and possibly dramatic benefits for patients being real in a number of settings. So it's a big challenge, Sue-Ann, and I know it's unfair, but I wonder if you might be willing to just set the scene a little bit and give us a broad outline of oncology practice and the big sort of changes that you've noticed over your career.
Yeah, so it's been a very exciting career, actually, to be part of this field. But as you said, the first, I guess, 2/3 of my career was about in chemotherapy to treat cancer. And as most people would know, chemotherapy damages DNA, and that's how it stops cells dividing. And that's really not very targeted. And so there's damage across many cells and leads to side effects that we're all familiar with. But over the past, and the incremental gains, by and large, were fairly modest, as you suggested. But, we thought incremental gains were still important. And so we, pressed on with the research of one chemotherapy versus another, etc. But really in the last third of my career, there's been an explosion of new drugs. And this has been underpinned by a very much deeper knowledge of the molecular basis of cancer. Which, that hasn't happened suddenly. There's been a lot of work in the background to achieve that. But molecular abnormalities or aberrations found in the cancer can now be targeted by some drugs. And we call that targeted therapy. And that really is the focus of oncology going forward. And most of the clinical trials are focusing on that approach. In terms of the different types of targeted therapies, we refer to them as the MABs and the NIBs. So monoclonal antibodies or small molecular inhibitors, the NIBs. So the monoclonal antibodies, people will be familiar with things like Herceptin, which targets a receptor on breast cancer cells, or Avastin, which targets VEGF receptors on cells. And so they work by targeting a receptor on a cell and then altering that way that cell grows and divides. And usually those drugs typically have just had one target on the cell. Immunotherapy drugs, which have had a lot of attention in the media, are part of the MABs. And they work in a different way. They sort of unlock the checking system that's on the immune system to allow the immune system to be razzed up, if you like, and attack the cancer. That's a very simplistic way, but that has been, really very successful across a number of different cancers, and we're using those drugs a lot. In terms of the NIBs, they're small little molecules that get into the cell and change things within the cell itself, rather than on the surface of the cell. And that property actually is very important to treating or managing brain metastases, because they can get into the brain like chemotherapy and the MABs can't. So it's a special feature. But so they're the kind of differences that have occurred in my career. And as you said, it's really been hard to keep up with all of these developments. If that's not exciting and cool enough, now there's even more fancy drugs and compounds where some of the MABs are targeting two targets at the one time with the one compound, so having an additive effect from their therapy. And then there's a class of drugs that are being used very commonly now, the drug conjugates. So an antibody is linked to a chemotherapy molecule. So the antibody will get that chemotherapy into the cell, release the chemotherapy within the cell itself. So having a very sort of targeted approach to chemotherapy. And so so these are very fancy drugs, but these drugs are in the clinic right now being used, and more of them are coming. So it's kind of targeting the chemotherapy to the cancer cell, which we've never been able to do before. So really, incredible advances.
Bravo, Sue-Ann. Thank you. Brian, the challenge has been laid down. Could you do a parallel sketch of palliative care practice over your year? Maybe evolution, new areas of focus, etc.
Thanks, Jenny. And it's a hard act to follow in some ways, because many of the examples that Sue-Ann don't have great parallels in palliative care. So I've just come from clinic, and the oxycodone that I prescribed for 2 of the 4 patients I saw is the same drug that I prescribed in 2003 when I was an oncology registrar. And interestingly, of late, as many people would know, we've had some of the opioids that are available that we prescribe for patients with severe pain removed from the Australian market. So drugs like hydromorphone, long-acting tablets. And I heard today that fentanyl patches will be in short supply over the first part of next year. So it's that sort of sobering news that makes me wonder whether we are changing all that much. But then I listened to one of my colleagues, Aaron Wong, who's completed a PhD looking at areas of pharmacogenomics, which is really the study of our genes that might help predict how our patients respond to opioids. And that's always been a question, because there are some people who respond really well to symptom treatments and others who have refractory symptoms. And maybe there are particular individual factors, like what Sue-Ann was saying, within individual cancers that might predict some of those responses. Since 2010, which is when the Temel paper was published, which was a paper looking at early palliative care intervention in lung cancer at Harvard in Boston in North America, that showed improvements for patient outcomes and care for patients receiving palliative care. And prior to that, there were other studies, but none as famous as that. And that really led to at least 5 or 7 years of every palliative care conference having really a major section devoted to describing benefits from early palliative care. I think other things that have changed are the way we deliver care. So to a certain extent, new models like your own model, Jenny, of Care Plus, where we provide outpatient palliative care, perhaps for a short period of time at the start of the illness journey, and then come in as needed, I think are different models. And I think there have been blurring of the lines of community-based versus hospital care to a certain extent in some areas. That all said, so I think we understand more about how to communicate with patients from different backgrounds, including First Nations patients from different cultural and linguistic groups. I think we know a bit more about how to look after kids with life-threatening illnesses. I think we know a bit more about how to look after people with multiple comorbidities as well. So not just cancer, but people with renal failure, airways disease, and heart failure as well. And many of these things will also coexist in people with cancer as well. That all said, I think there's lots that we can do better. I think that many of the adaptations that we have made in our services have been because of pressures of workload and pressures of how we do things. And I'm not sure that our system would look exactly the way it does at the moment if we were able to design it from scratch today. But would we want different providers in the home versus in our consult teams versus in our hospice units? I don't really think that we would. Would we design it differently if we could? Yes, I think we probably would. Do we want people to be able to receive care at home or in their place of choice as much as we would like? Yes, we do. Are we really achieving that? No, we're not. Are we part of the barriers ourselves sometimes? Yes, I think we are. So I think that lots of change. The other big change, I think, has been telehealth. So I think video technology just like this. I don't know if you remember, Jenny, but we tried to video link to someone in China just before the pandemic. It was 2019, and it was hopeless. It was Skype or something. It was jerky. We couldn't understand. There was a language barrier, but we couldn't understand what the translator was saying. There was no video, and yet here we are with 107 people online talking freely. And we do this with patients all the time at PMX. 65–70% of our consults for outpatients are still via video link, and that's great for many patients and their families. So lots of things to think about into the future, how we use technology, how we can remotely monitor patient-reported outcomes. Is there a role for artificial intelligence? Can we develop better therapeutics? Can we develop better strategies to understand and empathise with our patients? I think we can, so lots of work to do too.
Thanks, Brian. Thank you very much for that. And you know, the good and the areas of needing attention. But and it's interesting, isn't it, how adversity such as COVID has sort of enabled some other things to happen, such as this, and as you say, more importantly, perhaps telehealth. Mary, over to you. In the last, or over your career, over the years, what are the big changes that have been evident to you? And I guess particularly talking from the field of lung cancer, but don't confine yourself.
Yeah, it's amazing, and it's been lovely listening to both Sue-Ann and Brian succinctly reflect back on their careers. And my career as a lung cancer nurse started, as most oncology nurses do, in the inpatient setting, and very clearly identified as the vulnerable group of patients with lung cancer and mesothelioma. And of course, there's no space that has changed so much in oncology as the paradigm, the pathway of people with lung cancer. When I started my lung cancer nurse career in 2002, I never dreamt, and many of us didn't, that we would have the privilege and the science, and we always had the hope, of course, in the research, to think that we would have patients with stage 4 lung cancer living for beyond 10 years and plus. And now, of course, in our clinics, we have many of these patients, thanks to the trials that Sue-Ann talked about, who are living very long lives. And some of the things we concern ourselves about is, do we look after them well from a survivorship point of view? And you know, they're actually thrivers, and because they're probably actually neglected because we don't have the capacity in our systems and in our workplaces to adequately decide, you know, work out what it is about them, those people in their lives and in their homes and in the communities that they live in, that we don't know about, that we could perhaps help with. And I think it also makes us think about the notion of, like Brian touched upon, the notion of providing the care people require and need in their community, not in the oncology and in the cancer community, is one thing. But I think the other huge thing for me is, and it's been terrific to see that there's been some terrific, robust research come out, predominantly of the UK. Angela Todd in Sheffield did an RCT that actually demonstrated that lung cancer nurses in position actually changes the clinical outcomes and with improvement for people with lung cancer, and indeed also with people with mesothelioma. We don't have any meso-specific nurses in Australia. But to me, that has been just groundbreaking, and it's been great to see here in Australia the advancing of and the acceptance and the credibility that us as lung cancer nurses have. And we talk about delivering our models of care, delivering care to the people we look after in a multidisciplinary team, which includes us as nurses. And we're very privileged, I think, here in Australia to have the terrific relationships within our teams. We're very fortunate. Jenny Phillips sits in our Thursday multidisciplinary clinic, and it's just made such a difference to the way we can, you know, tap into other experts on our team for advice very beautifully. And that makes a big difference to the patients we look after, because they still get, like, you still see, like Brian talked about, you still see some torrid symptoms that we can help with, but we can help with them as like we're in a beehive. We need everybody together doing their little bit, and then we can make people feel better. And of course, the most important people in the multidisciplinary team is and will always be that patient and their family. The other thing that that has been terrific in my career for people with lung cancer and mesothelioma has been that great advancement and acknowledgement of how, and Sue-Ann's work is looking at that, but the actual reality of the supportive care needs, whatever title you give it, that people need. They've got an oncology disease, they've got early stage or not, and they've got symptoms, but they've also got other areas of their life that we need to have in the parallel lane and the highway that we also give attention to, and help people be well, help them, talk to them about what their goals in life are. Do they want to try and get back to work? Is that important? I'm not going to mention finances because we know that transport and finances are some of the key things that people are very real to the people in the community. But of course, in our systems currently at the moment, and there's the things we've got the least amount of assets in our toolkit to be able to realistically make a difference. But one of the things that makes a huge input for me in my career always and today and reflecting back is that wonderful trusting relationship we have with patients and their families. And there's nothing better, I think, than being in clinic or being on a telehealth or on the end of a phone, regardless of how long it takes, to make sense of what for the patient who's in front of you or you're on the phone with, and helping them. I don't have an Australian accent, so I understand the different patients struggle to understand me at times. So it's lovely, though, to be able to help them interpret our language and translate it, because we're shocking at using acronyms and shortening things. And it's lovely then to be able to have that conversation together and translate back out what we're talking about and help them translate into us what's important to them. So to me, they would be, I mean, I'm very fortunate as a lung cancer nurse that I get to do that and to work with a great team. And I'm going to stop there because I'll wax on for ages, as those of you who know me are aware that I will. But can I just say, I feel very privileged as a lung cancer nurse to be asked to take part in this panel. So thank you all for that opportunity.
Oh, Mary, you're perfectly placed to do so, and you know, it's great to hear your reflections on this important issue. I'm just going to take a little sneaky question out of session, which is, I'm just wondering, so Mary mentioned the supportive care needs, and this has been one of the sort of things that I've wondered a little bit around palliative care, and how, for patients who are earlier in their journey, and how we and who supports their supportive care needs. I wonder if anyone wouldn't mind having a think about that, or we can just leave the thought hanging.
I can chip in there. Just to reiterate what Mary said about the role of the cancer coordinator, or they're different terms for the same thing, but nurse practitioner or whatever. I think that has made a big difference in support. There's trial evidence, as Mary said, to suggest the benefits of such roles. I think in Victoria, probably in Australia, don't have, in some places, easy access to people like me, and there's a need for us to try and sort of formalise that role and get more of that role into our health services because of the, you know, the very important role cancer funding opportunity right now as we speak for some extra cancer nurse coordinators funded by the federal government. So I think there is recognition now of the importance of that role in supporting people with cancer through the whole trajectory of their illness, really, not just.
I think that's a really interesting question, Jenny. Just a quick story. I remember in 2014, I went to a conference in America, and this was in the post-Tamil period. So it was a palliative oncology American Society of Clinical Oncology conference. It was the first one, and everyone was very excited. And the conference started with one of the sort of leaders of palliative care oncology giving a patient history, and it was someone who was diagnosed with a breast cancer whilst pregnant. And for any of you who've looked after someone in that situation, it's pretty fraught. And to know what to do with the unborn child, as well as ongoing fertility, as well as diagnosing and treating and staging the cancer even. And the comment of the person was that this person needs palliative care. And I remember sitting with colleagues thinking that this is pretty way outside our skill set to know what to do. And I was thinking, this person needs a skilled and compassionate oncologist working in tandem with a full multidisciplinary team, which might include a palliative care specialist. But, this is well outside our wheelhouse. And it brings me to today. One of the jobs that I've set myself probably for 2025 is thinking about renaming our clinic from the palliative care clinic to the supportive care clinic. And that might be a surprise to you, Jenny, because I haven't mentioned it to you yet, but it is something that's been on my mind for a while. And I'm slowly socialising it, and we apparently have to go to the Department of Health to change our name for our clinic. But it does raise the question of exactly what you said. What do we do with the broader concept of supportive care? So we know that more younger people are being diagnosed with cancer now. So we see 30-year-olds with metastatic colorectal cancer. We always used to see that, but it's not uncommon now. It's certainly not as uncommon as it used to be. We see young people with lung cancer, many of whom will have a mutation. And for many of these people, they will have different needs, some of which are palliative care, but some of them do relate to fertility, to psychosocial needs. And we're not very well positioned in palliative care necessarily to look after all of these things. We might have people we can talk to about it, but and referral basis, but we're not a one-stop shop for every supportive care need under the sun. And I think it really challenges us to work out how to look after patients, many of whom will have an increasingly chronic exposure to cancer. I also think, to be a bit contrary as well, I think we've heard the positive stuff from Sue-Ann and Mary, but what is it, 10 to 15% of people with lung cancer will have an EGFR mutation. And I think that if you get diagnosed with lung cancer today, you'll hear about all the positive stuff in the news, but the chances are you might not have a treatable mutation. And I think that makes it really tricky for some patients to say, hey, how come I can't access this new stuff? And often their prognosis might not be that much different to what it was 10 years ago. They might be getting exactly the same chemotherapy that I used to prescribe when I was an oncology registrar in 2003, and their outlook might not be that different. So I think there is a challenge here that things are changing, but for many people with cancer, things are not that much different to how they were 20 years ago.
Yeah, I agree with it, but what you said there, Brian, and it is absolutely right. There is still bad cancer in 2024 that can cause bad symptoms and baffle a lot of us. But going back, Jenny, to your question, I think we all have a skill set that helps deliver and manage the supportive care needs. And I think one of the key things we have to be, in my own craft group in particular, and I'm sure my allied health colleagues would agree, it doesn't belong to any particular group. It belongs to the patient, and we all can contribute something. And as we're talking there, like, the shame and stigma attached to lung cancer has been recognised, and some great work done here in Australia by our colleague in Queensland. And we talk a little bit about it, but there's been no shift in that. People are still judged and meant to feel terribly ashamed if they get, and even more so if they don't have a mutation-driven lung cancer that can have some of these new fancy and very expensive drugs. And I suspect there's a lot of other cancers that have also got a lot of shame and stigma attached to them, that even have less of socializing, to take Brian's word, than lung cancer has. And I think we've got much more work to do than we have for the next 2 decades regarding shifting the societal and the community viewpoints and the philosophies, and not just out there in the community, also, if we're honest, within some of the people who we might be working alongside. And that in itself is no mean obstacle to put into 2025, with Brian changing the title of his clinic with the help of the government. We don't know who to go to get the help, and I go frequently to our wonderful psych oncology team and our allied health team, and what's great working in teams though is being able to go, look, this person told me this, and this, and I can see this, and this, and I can go to Sue-Ann, I can go to Brian and Jenny, but I can also go to my psychologist and in the interdisciplinary team value and say, I don't know what to do here. What's anybody's thoughts? And that's just wonderfully refreshing to be able to do that. When I started my nursing career as a lung cancer nurse, nurses didn't do that.
That's fantastic to hear, Mary. I really, what a long awaited for shift in how the whole system works. Thank you. I wanted to pick up on that sort of options for treatment, and I guess maybe touching on the optimism around treatment, and ask you, Sue-Ann, with all these different options available, can you describe, has your sort of practice with families, or how you navigate this space with families and patients and families changed, particularly, I guess, as they're progressing through treatments and becoming a bit frailer?
Yeah, I think, because of the media attention to a lot of these fancy drugs, blockbuster drugs, patients and their families often come with knowledge or an idea about treatment. And as Brian said, this treatment's not for everybody. It's still only a subset of people that can get these blockbuster drugs based on the molecular pathology. So managing expectations is one thing. The other thing that I think would be interesting to talk about, I value other people's opinion on this, it's a kind of end of life stage when patients are getting frailer, as you say, their performance status is declining. And usually our paradigm would be that treatment in that phase of people's lives is of low value. And we have seen that chemotherapy use in, the last month or two of life decline, which we think is a good thing. Because it means that they get more palliative care and they don't die in hospital, and all the reasons that we know. But I think that paradigm seems to be being challenged somewhat by these drugs. We've all got examples of exceptional responses where patients' cancers have, they've got up off their bed and walked out of the hospital when we were thinking about sending them to the palliative care or a palliative care admission. And so you don't forget those kind of instances. And so it really is a challenge when you know that these drugs are available. Are they of value in this setting? Are you going to be the one that gets up off the bed and walks out of the hospital and has good quality of life? Probably not for the most part, but we have these examples where it has happened. So it's really, and I think there is some early evidence actually that the use of these targeted drugs is increasing in that end of life sort of phase. Whether that's a good thing or not, I'm not sure, but it is a challenge to navigate that expectations with patients and their families around that issue. I don't have all the answers. Be interested to hear what you and others think about that paradigm being shifted at the moment because of the hype and the exceptional responses that we do see on occasion.
Thanks, Sue-Ann. Brian, did you have a thought on that?
Yeah, it is. What I've often thought is, when did it become like an empowering thing to go see your oncologist? You know, when I was doing oncology, generally people weren't thrilled to come and see me, but now, because of the headline acts, it is, you know, the paradigm has shifted in that there are, you know, people are quite hopeful when they come to oncology now that, you know, we build whiz-bang comprehensive cancer centres in your regional town because there are so many more options. But I do worry that, you know, the average person hears that you've got, you know, a 10 to 15% chance of having a target, but they don't realise that means that there's an 85 to 90% chance that you won't. They hear people, you know, Charlie Cork talks about this, that people genuinely usually feel that they're lucky, even if they've been diagnosed with cancer and they don't hear the probabilities. I'm not sure that that's a big problem for palliative care, though, in itself, because we've often, I think what we do more and more is hedge our bets. So we say, you know, hope for the best, plan for the worst type discussion. And we, funnily enough, palliative care is often not the ones to be breaking bad news or making the decision about shifting to best supported care. We're the ones that pick up after that. So funnily enough, some of those decisions are not, you know, within our sphere to make. And we're often in a position where we sort of hedge things and say, you know, if things get better, great. If they don't, then we're here to look after you no matter what. I think it's, I think where it probably has shifted is that because oncology is this positive thing now and that there's always another treatment option, that palliative care is very much now the end of the road for a lot of people. And you know, as try as we might, the thought that, you know, upstreaming palliative care is the right thing to do and you know, empowering for people, I think the message is louder and stronger than ever that palliative care is for the end. And you only have to, you know, listen to stories about people responding to treatment and saying that, you know, they were offered this new treatment or palliative care, and, you know, imagine what I would have done if I, you know, imagine I wouldn't be here now if I chose palliative care. You know, those stories abound, and I think it behoves us to try and walk this line for people that, you know, the support will be there regardless of, you know, their choices and their outcomes with therapy. Have we lost you, Jenny?
I am here, but I'm a bit worried. I'm hopeful that maybe I've just given it a little bit more energy. Can you hear me?
Yeah.
Yes.
Thank you. Thank you. And I guess I'd just like to comment on that too. I agree with Brian that often it's not us that has to make those tricky decisions. They often sort of sit with you, Sue Ann. And I guess the only comment I have is I wonder what, if anything, people are missing out on if they have another round of treatment, or like what's the cost of that for them in terms of their life events and their life completion, and that probably differs, you know, profoundly for each individual. But you know, I don't envy you. I think it's tricky.
Yeah, I think it's setting expectations is critical, I think. So as Brian said, only a small number of people a target is found in their cancers. They line them up for a biopsy, but there's a lot of ifs to getting that treatment at the end of the day, that the tumour sample's good enough to be tested, that a target is found. If a target's found, there's a drug for that target. If there's a drug for that target, is it available in Australia? So there's so many, you know, hurdles to move through to get to that end point. And by and large, most people don't get to that. So I guess I'd try and spend my time setting the expectation that this is a long shot. You know, do you want to do this? Is it going to take up your time? Blah, blah, blah. So trying to set expectations is, I think, pretty important.
Yeah, I absolutely agree. Thank you. Just on that, Brian, clinical trials are sort of a mainstay of a lot of oncology treatments almost now, in a lot of ways. And, you know, I'm sure all of us have been involved in the care of people who are on clinical trials, including until quite late in their life. I wonder if you can comment on that sort of interface of palliative care and clinical trials and tensions or otherwise.
The only thing I can say is in my own practice, I certainly try to make it not a tension. I think that there is the risk that it could be, and you know, for many of us, we might think we know what we would do when we're faced with our own terminal illness, but the reality is we can only guess at what we ourselves will be like, and it'll be, you know, for myself, it'll be probably depend on how old I am, how old my kids are, you know, where I am in life, whether I pay my mortgage or not, all sorts of factors that I can't necessarily predict now. So I think that we have to understand that for our patients and their families too. And so I think that means that it needs us to be flexible. So, you know, the biggest, you know, a common situation is someone is on a newer immunotherapy trial and they can't have a corticosteroid that might inhibit their response to treatment, or they can't have a drug that prolongs their, you know, an interval on their heart tracing, which is an analgesic drug we might want to use, or you know, that's where tensions might arise. And it also, so that might be, you know, that affects our prescribing and our treatment of various symptoms. But the other thing that being in a trial, particularly as your condition is progressing and towards what we would sometimes think is the end of life, is that trials, you know, a phase 1 trial is not actually about the response, it's about the safety of the drug. But how many people would participating in that trial, they might understand that, but in their heart of hearts will also be thinking, surely, that, you know, maybe this is the magic, the next blockbuster. And I can imagine you can be told repeatedly that, you know, it's a phase 1 trial, we're not looking for efficacy, but I can imagine that, you know, they would be hoping that they would. And so how do you marry that thought of hoping for the best, but planning for the worst too? It is a hard street to walk on, that two-sided thing. But, you know, that's where our patients are, and I think we have to be there with them, acknowledge that uncertainty, and you know, do our best to fit those patients into our system. And I think the challenge for palliative care, what the challenges are for palliative care, is that we have so much dogma in our system. You know, one of the KPIs that community services report to the department is, you know, death in place of venue of choice. And that means you have to ask the patient where they would like to die. And to me, that is not necessarily the question you ask when you first meet that person. But, you know, you have to fill that out in the case note, or, you know, if you tick, you know, question not asked, you feel like you're copying out because you haven't done that. But, you know, we have to be flexible to what our patient needs. And, you know, if they don't want to talk about that, or if it's not appropriate to ask, it doesn't mean that that person doesn't want our support. It just means that they might not be ready to get to that point yet. And we need to be amenable to that. Our systems need to be able to adjust to that. And I think that's part of the challenge that we face in you know, when we've got 10 people on the waiting list to see and only, you know, 2 spots to fit them in, whether that be a community service or to an inpatient palliative care unit or to an outpatient clinic. You're going to, you know, sometimes draw lines, and we have to make sure that we draw the line in the right place to prioritise people, and not, you know, exclude people because they might be, you know, participating in a clinical trial, or you know, have different acceptances of where they are in their illness trajectory.
Thank you. Mary, you've worked with many people who are hoping, and there's that possibility, and it might work out or it might not, and that, you know, some of that uncertainty or that optimism has you know, been, you know, made more possible in lots of ways. I wonder if you wouldn't mind reflecting on that, you know, people living with uncertainty in the hopefulness of perhaps the clinical trial being the thing, or but also needing to think about what if not.
Yeah, and that uncertainty and managing expectations, both for the patient and for ours and our teams, is quite challenging, isn't it? And I often say, I often use the analogy of a weighing scales with patients. So now there's probably digital weighing scales that look different, but you have to balance your weighing scale of life with certainly hope and not denying people access to whatever is available for them. But you also have to be pragmatic and practical and plan, you know, get the scales right. It's very hard. Even in wellness, we don't always get our scales of life well balanced, and then throw in something into you know, like cancer. No one ever puts up their hand to voluntarily come into a cancer centre. They might view nowadays coming in to see an oncologist differently than they did 20 years ago. But that uncertainty that the word cancer and cancer treatment causes for somebody's life hasn't shifted all that much, being honest, and the stories of life remain the same. And people's, and I think the bravest people in our clinics, of course, are the patients, but the next bravest, they're equally brave, are the oncologists who have those hard conversations that you mentioned earlier. But I think the other thing is we always think we have to do everything in one sitting, in one appointment, but of course we can unpick and unravel threads of the tapestry of somebody's life in little bits, and we can talk to them about, you know, and we do, don't we? We talk to them about, okay. I remember once a young man, one of the youngest patients, the early youngest patients, who was diagnosed with metastatic lung cancer, and he whenever I'd mentioned the word symptom control or palliative care, he'd actually get up off the chair and he'd be twitching around the room. But over time, and after building up a trusting relationship, you were able to, and his name was Matthew, he asked me to tell his story, and I've been proud to do it many times. But in the end, you'd say, okay, I'm going to talk about something now. I want you to sit in your hands and just let's have a conversation about, you want to go to Japan for a month. How about we talk about traveling? You go down to Warrnambool for a week and see how we can manage that. So, you know, I think we have to sometimes, what cancer has done for us and for the people we care for is challenging our communication styles and skills. And there's many things as clinicians we can learn from reading Google, going to lectures, having fantastic training, which I think is really, really important. But the most important thing is having our own communication style that matches the communication style of the person you're communicating with and to. And the uncertainty, yes, some problems have no solutions, but you can change it. There's more than one way to slice a chocolate cake. And we slice chocolate cakes in many different ways every day in oncology and palliative care clinics. And I wouldn't, you know, you can't say that. You can use different, but you have to. We've all got a little store of golden wisdoms that we use to talk about the uncertainty. And of course, sometimes it's our own uncertainties, particularly this time of year, regardless of what your background is, who you are. And even if, you know, there's a certain life revs up in all, certainly in the Western worlds, from, you know, November, December, January, February, because there's a whole lot of changes taking place. There's the people wanting people want you to tell them with a degree of certainty that you always can't, that they will see this Christmas, even though it might be their last Christmas. And you can't lie to people sometimes. You have to be honest, and or you can say with confidence, we've no reason to think that it won't be. But I think we have to be honest with ourselves of regarding the uncertainty, and everybody's different. Every human being is unique, aren't we?
Well put. Thank you. And the honesty with ourselves is sometimes the hardest thing in a way, when you're sort of really barracking for someone. And yeah, thank you. I had a question, and I might just throw it to Brian in the interest of time. So the TEML study was pre all fancy treatments and availability of things in lung cancer. Early palliative care, what do you think it sort of looks like in now? Or what should it look like? Maybe what should it look like?
Oh, that's a tough one. And I think there are probably people online who are texting me at the moment saying that I look tired, who are probably better placed to answer that because they actually looked at some of the TEML data. But what does palliative care look like now? So as you know, we've had some early palliative care projects, and some of the comments we initially got back were, why are we seeing, this is from a palliative care viewpoint, why are we seeing them? They don't have any symptoms. We're just touching base. I think it's about well, my viewpoint is it's about a relationship. It's about what I'd like to think is some people see me and they're fearful of what seeing me might bring and what it portends in their illness. But I hope they don't mind me, and that they, I generally try and keep it a bit light at the start when meeting people, and hopefully it's about establishing a relationship such that if and when things aren't going so well, we have had a previous encounter that we can build on. And maybe that's a bit about what it's about. Maybe it's not necessarily, prescribing the opioid or asking about their bowels, or, not that stuff's not important, but perhaps early palliative care is not so much about that. And I'm not to say it's about completing the advanced care plan or writing a will or all of those things, because I think to a certain extent, even people are super positive. No one hears that they've got a cancer diagnosis and doesn't start thinking about their life and the implications for them. There's very few patients that are so optimistic that they won't have even thought about that for a moment. But I think the role for palliative care is establishing the parameters of what that relationship might be in the future if and when it's needed.
Thank you. So we're sort of coming up towards the hour, and we like to finish these panel discussions on asking each of you to comment on a quote. And I struggled to find one for this, but anyway, I came up with one from Eric Fromm. And I would like to perhaps ask you each in turn to give your reflections on this. And the quote is that the quest for certainty blocks the search for meaning. Uncertainty is the very condition to impel man or woman to unfold his or her powers. Sue-Ann?
Yeah, okay. It's there's a lot in that, a lot could be said about that. But I guess in the spirit of discussion about advances in oncology, the uncertainty, this is very relevant to cancer care. We have a lot of uncertainty. Patients and us as healthcare professionals are often faced with ambiguous prognoses, evolving drugs, outcomes that are not predictable. And I've witnessed in my career that this uncertainty has motivated innovation. It has pushed for breakthroughs in treatment and has challenged the status quo, all in the pursuit of improving patient care. I think that's my initial reflection. There's a lot of more sort of personal reflections, but I think I'll leave it at that and let other people have a chance to speak to this.
Thank you. Brian?
I was hoping that Mary was going to.
I thought Mary might bring it home.
Oh, yes, good point. Look, my initial thought actually is that quote's a little condescending, really. The thought that you need to be uncertain uncertainty gives you a space to derive meaning in your life. I think uncertainty breeds anxiety and fear for me, and I'm sure it does for many of my patients. And sure, I think a population does then come to an understanding and a ability to cope with that uncertainty. But for many people, it's just crap. It's terrible. And I know myself, when something is uncertain, it makes you feel uncomfortable and out of place. And so I think that meaning really should be derived around what is important for that person, and trying to capture, maybe it's about trying to capture that person's importance and meaning amidst the uncertainty as being important, and trying as best as we can to map out or to work with that person to map out some of their ways through the uncertainty is the meaning.
Thank you. That's sort of in some ways it's an important clinical task as well, isn't it? Thank you. And Mary, your thoughts, your reflections?
Yeah, I don't think uncertainty is a bad thing. I think there's a sentimentality about being a human being that we need to allow ourselves to take charge and hold on to, and also our patients and their families. And I think that quote almost causes you to feel like a moral injury, because it means it's not okay to that uncertainty is a bad thing. We're humans. We're flawed, and that's okay. The sentimentality of life should be embraced, and hopefully we do that. I think I'm not going to bring this home, Jenny O'Brien, but I think in oncology and palliative care, we have this amazing privilege to be involved at and trusted by so many at an incredibly high level. And, who doesn't love that? I know nothing about cricket, but I'm going to be careful in my next comment. I love listening to cricket, even though I don't understand it, believe it or not. But I was listening to the cricket on the weekend, and they were talking about something, and I thought, oh, this could go for all human beings, not just for cricketers. They were saying when things aren't going well, lower your ego and escalate your ability. And I think sometimes as clinicians, we need to do that a bit, don't we?
Perfect, Mary. Thank you.
Definitely brought it home, Mary.
Lower your ego and escalate your abilities. Thank you.
We're not quoting that person correctly, but that was more or less the gist.
I think you will all be joining me in thanking our wonderful panel for what's been a really rich and thoughtful and fun and moving discussion this afternoon. Lots of hands and hearts. So thank you, Sue-Ann. Thank you, Brian. Thank you, Mary. Thank you, Tanya, for all the organisation that takes place to make these events happen. And thank you to you, the audience, for coming along on your Wednesday stormy Melbourne afternoon. I hope everyone has a terrific summer and a interesting and safe and happy festive season. And we look forward to seeing you at the Perspectives next year. So thank you, everyone. Again, thanks to our panel, and good evening, everyone.